have two of our GW second year ID fellows who are going to be presenting on interesting topics from the ID Week conference that was in October. And so the first fellow is Dr. Sarah Turki, who is going to talk about some talks she went to about women living with HIV and menopause. So Sarah, if you want to share your screen.
Yes. Hello, everyone. Sorry, not sure what's going on. Let me see. Okay. It won't let me share the screen. I'll try again. Okay. Okay. I don't know how much you can see from the screen. Do you see a lot or?
We can only see your Zoom screen, actually.
My what?
Your Zoom screen, so we can see the Zoom through your screen. We can't see slides or anything.
Oh, okay. Maybe I chose the wrong thing.
Sarah, otherwise, if you want to let Alex go first, then you could always email your slides to Aniko and she could just share them. If you want to try that instead.
Sure. Maybe Alex, if you want to go first.
Alex, do you want to try seeing if you can share yours? So let me introduce our second presenter. So Dr. Alex Ogilvy, also one of our second year ID fellows, who was going to share some of his takeaway on some talks he went to about HIV and mental health. And we can see your slides. We're seeing it in presenter view, so we're seeing your next slides, which is...
Yeah. Let me just find the right one then.
Yeah.
How about now?
Perfect. Thank you, Alex.
Okay, great. So this timed in, when I last timed in just under 12 minutes, so I'm just going to go ahead and get started. So I am presenting on HIV and mental health, an intersectional approach to care, and this is based on the Peace of Mind session by Dr. Vijayan at ID Week. So there is a high association between HIV and mental illness in the United States. Rates of HIV acquisition are 4 to 10 times higher in those with mental health issues, and there is a 2 to 6% prevalence of HIV in those with serious mental illness as compared to the general population, which is 0.5%. Those living with HIV also experience mental health disorders at higher rates than the general population. In one study, 36% of persons living with HIV reported depression, 15.8% reported GAD, compared to 6.7% and 2.1% respectively in the general population. In addition, persons living with HIV and mental health disorders often face other challenges on a variety of different axes, structural factors like poverty, low education, unstable housing, and food insecurity. Environmental factors such as unsafe living conditions or risk of violence, and biological factors like comorbid illness, both communicable and non-communicable illness, and intersecting social factors such as drug use, sex work, and same-gender sex. Data from the CDC report that up to 29% of persons living with HIV ages 25 to 34 report an unmet need for service by mental health professionals. 23% of those ages 35 to 44, and 20% of those ages 45 to 54, and 17% of those 55 and older. Mental disorders can present a barrier to adequate engagement and retention in HIV and primary care. There is also a connection between CART adherence and mental health that has been closely studied. In a large meta-analysis, the rate of good adherence was 42% lower amongst patients who had experienced depressive episodes compared to those without. So an example of these kinds of patients that came up in ID week was a patient named Aaron, who the presenter discussed, was a young man living with HIV and struggling with mental health. He also likely had behavior disorders and substance use disorders, and he had difficulty keeping his appointments and maintaining adherence with his combination ART, despite the best efforts of clinical staff. He also had challenging relationships with staff and frequently fired his providers. So the question that was posed during the session was, how do we help patients like Aaron who have numerous overlapping diagnoses that pose barriers to care and improve adherence to ART and other medical regimens? So there are three things that the talk focused on: addressing mental health needs, medical care coordination programs, and contingency management plans. So in addressing mental health needs, the goal should be enhancing adherence to both ART and mental health interventions. As previously stated, depression can pose a barrier to CRT therapy, but other psychiatric conditions can also make treatment challenging. One multi-site study of roughly 1,100 persons with HIV in 2009 identified that significant psychological distress and substance use disorders had a 45% less adherence to ART than control populations. In a separate 2020 meta-analysis, the odds ratio of non-adherence in patients with PTSD was found to be 1.19. The causes are multifactorial. Some conventional wisdom holds that taking daily ART can trigger reminders of sexual traumas that expose the patient to HIV, for example. Obviously, the easiest approach to addressing mental health is to connect patients with mental health professionals, which can be done through psychiatry consults and referrals, and also e-consultations if those are available. The presenters provided an example of how to write an e-consultation, which is basically similar to the way that we would send our normal consults, except this is all done through the EHR. And so they gave an example of what things to do: be specific, offer objective data, use validated rating scales, include pertinent history, include concurrent use of substances or other important collateral information, and include prior treatments and responses. So they give an example of what that might look like here, which reads, 25-year-old female with history of depression, anxiety, has reported worsening insomnia and anxiety despite current antidepressant treatment. Patient previously tried sertraline, which was discontinued due to nausea. She now takes fluoxetine, which has been increased to 40 milligrams daily without side effect. She feels that the medication was initially helpful for anxiety and mood, but has been less effective with new onset insomnia in the context of increasing stress at her job. She doesn't have any known family history of psychiatric illness or history of mania. Do you recommend medication adjustment or transition to an alternative medication? And then the psychiatrists will respond to you with a likewise detailed note to your question that should ideally include things like what next steps and sort of some contingency plans further down the road. So the next thing that we can do is medical care coordination programs. These are another tool that can help bolster adherence and retention. A QI study from New York from 2009 to 2013 found a CCP program which offered ART adherence support, case management services, outreach, patient navigation, and structured education curriculum increased adherence to care by nearly 20%. Ward 86 in San Francisco is another famous example of using CCP, using community outreach, medication delivery, and financial incentives to remain in care. An example that came up during the ID Week talk was incidental care that occurred when patients presented to the practice for another reason. Patients who had perhaps missed an appointment with their HIV provider were quickly seen by the provider after being notified by clinic staff of the patient's presence. For example, the patient presented to a psychiatric appointment, then the HIV provider could be notified and come see the patient briefly, even though it wouldn't be a formal visit, just to check in and see how they're doing. This also works in the reverse too, and psychiatric staff could easily see the patient quickly if they presented for HIV care. Coordination can be non-challenging and can be challenging rather in non-integrated practices, such as private offices or free clinics that don't have all the necessary services in-house. Another thing that is useful is a contingency management plan, which is been studied predominantly in the treatment of substance use and related disorders. So contingency management plans seek to reinforce desirable behavior through positive feedback systems, such as monetary compensation for continued sobriety. There are good data to support contingency management plans, and they have been shown to increase retention in substance use programs. One program used a lottery system where negative urinalyses offered participants a chance to win prizes between $1 and $100 cash value. Retention in these studies were 14% greater than the control, and results were even better for certain subgroups, such as stimulant use disorders, where abstinence throughout the 12-week trial was 4 times higher than control. Ward 86, as mentioned previously, implements similar contingency management plans by providing financial incentives to remain connected to care. Obviously, cost is one of the largest barriers to implementation of these plans. However, there are other reasons that they're not widely adopted. Other barriers include ideological concerns, a lack of coursework and training in behavioral analysis, and contingency management, disconnections between research and practice, and the general lack of awareness of these kinds of practices. Another thing that came up was the use of long-acting injectable medications. Although presently cabotegravir-rilpivirine, commonly called by its trade name Cabenuva, is only labeled for management of HIV patients with virologic control, there's a growing body of literature which suggests its efficacy as a first-line therapy, even in patients with detectable viral loads. The Latitude trial, for example, is a phase 3 clinical trial studying LACAB-RPV in patients who have adherence challenges when taking oral therapies. Early data from Latitude has been very encouraging, and there have been additional studies, such as data presented by Hickey et al. And Croy at Croy 2024, that found durable virologic suppression in otherwise uncontrolled patients. These data have been sufficient that the IAS USA guidelines have been updated to recommend considering LACAB-RPV in patients unable to take oral ART consistently despite adequate efforts. Other long-acting formulations are also being developed, such as once-weekly oral lenacapavir and cabotegravir-rilpivirine, which have demonstrated good suppression and adherence. The key here is options for patients, which allow patients to take ownership and control of their care. Some patients have difficulty taking a daily pill, but for those with a weekly routine, a once-weekly regimen may be more manageable. Like, say, if they go to church every Sunday, they can just take the medicine before church. For others, the discomfort of injections every 2 months is preferable to oral therapies. These benefits are not limited to HIV management either. Depot injections and long-acting injectables for psychiatric medications can help patients with difficulty taking a daily oral medication. One example might be long-acting cabotegravir-rilpivirine, depot olanzapine, and liraglutide to manage a patient with comorbid HIV schizophrenia and metabolic disorder. Putting it all together, we should know by now that managing HIV patients and mental health is a complex challenge. HIV and mental health are often comorbid, and either can increase the risk of the other. Integrated strategies such as coordinated care programs and continuity management can help manage these complex patients and assist them with adherence to their therapies. There's a Jesuit concept called cura personalis, which I think is applicable to persons living with HIV and struggling with mental health. These patients are more than the sum of their diagnostic codes. They're dealing with complex lifelong illness with complicated regimens and numerous side effects. Even the most well-tolerated medications can produce unwanted side effects, such as weight gain on combination SSRIs and combination ART. These patients are also often dealing with substance use, housing instability, poverty, and prejudice. So keeping in mind their complex needs and working to treat the whole person, not just 1 or 2 diseases in a silo, is critical to improving patient outcomes. More research, is required in the management of HIV patients. Long-acting ART provides good options for patients who struggle with adherence, but even our current options aren't great. A number of patients, for example, discontinue cabotegravir-rilpivirine because of injection site reactions, and it would be great to offer them a regimen that meets their needs without this discomfort. Likewise, wider implementation of contingency management practices outside of substance use programs is also needed to be studied to see if it's a viable strategy. More data may also help convince skeptics or persuade governments and insurance groups to provide additional funding for these measures. And so these were the references I used in preparing today's talk. And I thank you for your attention and would invite any questions you may have at this time.
That was really excellent, Alex. And I think you brought up some really valuable and pertinent points. You know, the Ward 86 data and that data by Hickey clearly show that in patients who have structural barriers, including unmet mental health needs, really benefit from the long-acting cabotegravir and rilpivirine. But, you know, as of yet, the CDC guidance is still that it is indicated for patients who are virologically suppressed on a oral ART therapy for at least 3 months. And it is really challenging to get insurance companies to approve cabotegravir or rilpivirine in patients who are not virologically suppressed. And it's basically a case-by-case basis, which it's unfortunate because the studies clearly demonstrate that that population significantly benefits from being able to just get an injection every 1 or 2 months. And in a lot of cases, it's the first time that they ever achieve virological suppression because they've just they've had so many unmet mental health needs. So I think that's really an important avenue to pursue and to try and figure out whether the guidelines can get changed. Tamara, you had a question?
Yeah, I just actually had a similar question to what you were just talking about, Mark, and it was really around, do you know how or what efforts have been made around advocacy towards shifting those guidelines to be more inclusive of if it's mental health screening or considerations for mental health? I'm thinking about how PrEP was initially rolled out, and then those guidelines were sort of slowly expanded and then completely expanded. And I'm just curious if there was any discussion around advocacy, might be too strong of a word, but around the process for expanding guidelines for long-acting injectables and the like, especially given some of the ways in which we know it could make it easier for people with some of these other unmet health needs and comorbidities be able to manage their HIV.
Alex, do you have, did they talk about advocacy at all?
They didn't really. Sorry, go ahead. Oh, no, that was me. I'm hearing myself. They didn't really touch on advocacy needs. This was kind of more of just a general, not how to, but more of a talk on sort of what sort of resources are available, unfortunately. I think, but I would say sort of based on my own knowledge, I would say that there's definitely an unmet need for advocacy in this realm of trying to get expanded indications for long-acting cabotegravir, rilpivirine, and I think part of the purpose of this talk was to just kind of make us aware of the options on the table for treating complex patients and to make us more comfortable with sort of reaching out and trying to like co-manage these patients with psychiatry very closely.
Yeah. And you mentioned that the IAS guidelines have now been updated to recommend using long-acting CAB-LA rilpivirine in certain patient populations who aren't virologically suppressed, right?
Yes. Yeah, that and those have the 3 criteria of inability to be suppressed despite adequate clinical intervention, no known adverse events to cabotegravir or rilpivirine, and having a virus which is susceptible to cabotegravir and rilpivirine. So if they meet those criteria, then the IAS USA guidelines actually do recommend attempting to achieve virological suppression with cabotegravir rilpivirine injectables.
The one other comment I would have as being a provider in DC is there's a dearth of mental health providers available to patients who are on Medicaid or AmeriHealth or Trusted or AmeriGroup. And so it's very hard for those patients to sometimes get their healthcare needs met. And, you know, I as a primary care provider and an ID subspecialist will try and manage at least depression. But when it comes to schizophrenia or bipolar disorder, that's out of my out of my realm of comfort, and you know, it's a challenge.
Yeah, and there is actually a shortage of mental health professionals. I think something around 40 to 60% of SSRIs are actually written by primary care physicians and not psychiatric specialists.
Yeah, yeah.
So Tamara, that path to kind of what Alex described. So with the FDA indication is for as a switch study for those virally suppressed. So when an indication comes out that has a very those specific indications, you know, it's incumbent upon us to show and the data for how we can use it differently and safely. And so these demonstration projects become really important, but they're difficult to fund. Which is why they're really done as effectiveness studies in the context of a clinical practice, for example, what happened in San Francisco, and then also with the study with the ACTG. So the proof of concept then is there, and the changes can be made to guidelines, which then allows us to be able to tiptoe into that space. Because in addition to, is it safe? Will it work? Is it tolerated? The flip side is we also have to get it paid for. And so maybe when it gets into a guideline of some kind, we can point to that when we do the prior approvals in order to be able to get these quite costly medications. The one thing I'll say is, I think they may have been a little bit ahead of their times. When I was working at Unity Healthcare, they had me start to go to Community Connections, which is one of the few places I know in DC that actually provides mental health services to persons broadly, to the DC community. It's in, I think it's south east, very near to the Capitol. And what they do is they got a grant and they tried to do co-located services for mental health, and they embedded me as an HIV provider into that clinic. But what they found, which at the time I was like, it was kind of for me, it was abstract, but people didn't want to leave their HIV providers that they'd known for ages, right? But now I think it would be a really good time to think about doing something like this, because you have something to offer that's very unique, which is an every 2-month injection that makes it very easier that you don't have to take tablets. So I see myself frozen. I'll just and I will let Alex go ahead. But I think there are things like that potentially could be facilitated, because to have an evaluation accompanying that kind of intervention would be really nice.
Yeah, I agree. I think in the interest of time, we should move on, but thank you, Alex. Very good presentation. Appreciate it. So Sarah, I think
are you able to see my screen, or no, not yet?
We saw something that when it said you were sharing a screen, but then it was just a smaller version of the screen with Seble on it. So do you want to try it again?
Yeah, sure. I don't know why it won't let me.
Did you send it to Aniko?
Oh no, I'll send it now. I think it's not going to work with my screen. So,
okay. Seble, do you want to just go ahead until Sarah gets
I can go ahead.
Yeah. Okay.
Yeah. So I selected to speak today about Mpox, mostly because there was a session on Mpox with a few speakers, and I thought I would just share, especially the study results that were shared looking at use of tecovirimat, the antiviral agent for Mpox clade 1. So just very briefly, Mpox is a virus of which we know that there are at least a couple of clades. It's a zoonosis that's present in animals that would spill over disease into humans. And typically what we see with human disease is we see sometimes a febrile illness with cutaneous lesions. And I've put here for you the mortality rate is very different for clade 1 versus clade 2, up to 10.6% for clade 1, up to 3.6% for clade 2. And it's in the same family as the smallpox and other pox viruses. So again, the portal of entry, usually skin, direct contact, oropharynx or nasopharynx, incubation of 7 to 21 days, and then you get viremia through the blood, and then spreads to skin where it manifests in the rash. So the incubation period after exposure, again, is 1 to 2 weeks, generally speaking, about up to 21 days. When you have disease onset, it's 1 to 2 days of this prodromal phase before you get the rash, with fever, headaches, body aches, fatigue, lymphadenopathy. The rash is a kind of a range, starts with macules, papules, progresses to form vesicles, then can be pustular, can be very diffuse, can have very few, but you can have very many. They scab over and then they crust and fall off. And someone could be infectious until there is full healing over of the skin. And there you can have complicated disease with pneumonias, CNS involvement, eye involvement, gastrointestinal involvement, where you can have a lot of diarrhea, vomiting, and dehydration. And we see more severe disease in immunocompromised persons, including persons with HIV with low CD4s below 200. And then also there's high-risk infection locations, so the eyes, the mouth and throat, and then the urethral areas where you can have blockage and urinary retention, etc. So there have been a couple, usually it's been very sporadic disease recognized since I would say maybe the 1950s. There was an outbreak in 2003 with importation of, I believe it was prairie dogs, where there were about 47 cases in the US, mostly in the Midwest, and from secondary transmissions there as well, that then died away. And then there've continued to be other sporadic outbreaks, mostly in sub-Saharan Africa. And then in 2022, there was an outbreak that was first recognized in Europe, then in the US. Globally, there were over 99,000 cases, 32,000 of which were in the US. There were 58 deaths in the US. And part of the response to this outbreak, we saw it primarily in MSM and then maybe others who had direct contact. And there was rapid escalation in use of Jynneos vaccine for prevention, and also introduction of tecovirimat, which is an antiviral agent used as investigational for Mpox that was then rolled out through expanded access. So Jynneos, again, was developed and in stockpile for potential use for smallpox if needed, which is considered eradicated, but there is a couple of labs where there are stockpiles of smallpox, and that's why we stay with these in preparedness. So in the 2022 outbreak kind of faded away. We have low-level sporadic infection still ongoing. But in the wake of this, since about 2023, there has been a clade 1 outbreak mostly focused in the DRC, but now with spillover into other countries. And again, it was mostly prevalent in there have been over 19,000 cases since 2023. And this was from an MWR that reported up to April 2024 data. There are additional cases since this outbreak is still ongoing. And very high prevalence was noted in sex workers, but it's men and women. And it's also been found, there's been secondary transmissions within household contacts, including in young infants and children. So the majority of cases are in the DRC and Burundi, but there has been spillover elsewhere. And again, the case fatality rate is much higher. So I just wanted to talk about our experience with the tecovirimat in the US, because I think contextually it helps to think about this when we look at the study that was reported in ID Week. So this report came out in the New England Journal of Medicine, and it reports the experiences with just over 7,000 persons. Again, all of this was done in the context of expanded access. So there were forms that were being filled out that gave information, but it was not a clinical trial. Most people were within 7 days of symptom onset. The median number of lesions was 15. Only between 2 and 7% in different groups had over 100 lesions. It was 14-day standard therapy. A very small subset, less than received more than 14 days therapy. Those were very immunocompromised persons. And those with resolution at less than 14 days may have stopped treatment early, but the majority were 14 days, about 89%. The reasons for administration was either pain, risk for severe disease, lesion in a sensitive region, or some combination thereof. There were very few that were done just for rash alone. And then 75% recovered without sequelae. And then the lower level of recovery was in those with immunocompromising conditions. There were 40 deaths, 37 of whom had immunocompromising conditions. And then this is just the epidemic curve here on the right in terms of disease cases that were seen. And then in the yellow is the tecovirimat administration. So knowing that, I put this in just so we have the sequelae here. I won't go through this because, again, it's just the time to recovery, the proportion of people who had full recovery at the time of resolution of completing their treatments, etc., and then the deaths, which I shared with you already. So this is what was presented in at ID Week. This is the PALM-007 trial, and the primary objective was to evaluate the clinical efficacy as assessed by time to resolution of lesions with use of TPOXX versus standard of care or placebo. Both arms got standard of care. And then they looked at a couple of secondary outcomes, dichotomizing by whether people presented early, less than 7 days, or greater than 7 days. They also looked at improvements in viral outcomes, detection by PCR in blood or pharyngeal or on the lesions, and then severity. They had 2 clinical sites that were in remote areas in the DRC. And they had follow-up at day 29, day 59. They hospitalized all the patients for these 14 days of treatment, and people also received nutritional support. So the highlights in terms of the characteristics of the patients, they enrolled, I think, just over 500 people into the study. And it was a very young study population. So the median age was 16. The median days since onset was 5.9 days. But there were a huge number of lesions, over almost 500 lesions on average. And you can see that there were some reported cases where they had over 10,000 lesions somehow counted, right? So 10,264 on the upper end on some of these. So really hugely symptomatic. They were able to detect by PCR and blood in over 50% of cases, over 95% by lesions, and then in the oropharyngeal area in about 88% or so. They had some about 20% co-infection with malaria, almost none with HIV, and then they had about almost 20% with poor nutritional status. And the highlight of what they found was basically they found no significant time to resolution with tecovirimat versus placebo, no resolution among those who presented before or after 7 days of symptom onset. So basically they had overlapping response rates irrespective. However, what you'll notice is that on average, it's about over 50% had resolution of their lesions by day 7 after treatment. So it's kind of very perplexing to me when you have this much disease, but you have this extent of resolution within such a short time period compared to what I told you about with what was reported with our experience here. So very few lesions. Yes, most disappeared by 14 days. But there was still some who had some symptoms, and full recovery takes a lot longer. They had no differences in deaths with or without tecovirimat. So you can see it's like 1 versus 1.3% overall, with the shorter time to delivery of the tecovirimat was 0.9 versus 0.8%. There was relative risk for, was 1.6 versus 3.2 for those who were later on in disease. But this was not statistically significant. And I did a quick little calculation, really to see, even a 2% mortality difference, they would have needed a much, much larger trial, because this really was just 120 people that were included here. And this is a hard outcome. I mean, this is a mortality outcome. So again, their conclusion is that there was no difference. And in terms of the time to non-detection, I think they had rapid non-detection in blood and on the lesions, but about 50% of the oropharyngeal samples continued to test positive even after at the end of the treatment period. Now, So there's a question of, is this going to contribute to ongoing transmission? But we really can't say if this is viable virus versus non-viable virus. So this week, a case was reported in California. I think the patient is being managed in San Mateo County, is improving, wasn't very severe disease. There have been a number of cases reported outside of sub-Saharan Africa at this point. There haven't been a lot of secondary transmissions. So this is very much on our minds when we see now a patient with Mpox, differentiating if this is the new clade 1B versus what we were familiar with, the clade 2 becomes important in terms of our testing. But also the takeaways for me were that we really have limited options for clade 1 Mpox surveillance and being vigilant to try to decrease transmission. Acknowledging that there may be higher mortality, I think is important, but clearly the underlying population characteristics are very different. But the disease burden that is reported in terms of number of lesions is just dramatically more than what was seen with the clade 2. Importance of vaccination to prevent infection. I think we still don't have, the entire population of those thought to be potentially would benefit from the Jynneos vaccine having received it. So I think that's an area of focus. And then really there was some discussion about potential alternate combination therapies, monoclonal antibodies, use of other antivirals, or some combination therein. But I think also just trying to understand what the endpoints are that are clinically meaningful is really important to think about, and how we define both our how long the infection has been ongoing, as all of those other things. I think there's a good amount of noise there. So I hope we won't throw out the potential use and utility of TPOXX, because I think Mark may be able to speak much better to this. People have found that it helps in terms of decreasing pain and resolving lesions in the kind of more, a clinical experience that we have. So I think these studies do need to be done very carefully so that we don't end up not using them when there really is potential utility, including a mortality benefit. So that's what I have from that presentation. It was very sobering.
Yeah, it's scary to think that, if and when we do see more cases of clade 1, what are we going to do? And are we going to say, well, based on the study, we're not going to use tecovirimat? And I think most of us will still use tecovirimat. It'd be good to have kind of a expanded access study similar to the tecovirimat study for brincidofovir, which is not widely available and would probably only be available through like an expanded access program, because, it would be good to know if there's something else. And to your point, I agree that my clinical experience seemed to suggest that it helped with patients who had Mpox in sensitive areas such as the rectum. But was that causation or association? I don't necessarily know. I know the more recent updated guidelines by the CDC no longer list proctitis as a indication for giving tecovirimat. And if we do see more cases and we have someone with severe pain from lesions in a sensitive area, it'll be an interesting discussion to decide whether we will or won't offer that person tecovirimat.
Yeah. So I think, these adaptive trials where you can layer on different combinations of interventions would be, that design should be in somebody's back pocket to roll out, because you'll also need a lot of sites to get it done. If we have kind of a, dripple in of cases as opposed to like a real outbreak like what we had before.
Yeah, and we'll see what happens next year. I always say that, we're hosting World Pride in DC, which leaves me somewhat anxious for the potential that we're going to see some cases in DC, and we'll see if the community is prepared. The other thing about mortality is, from what I remember, is 75% of the mortality in the clade 1 cases was in children.
Yeah. Did I see 39%? Anyway, it is a large number.
I thought the majority was in children, but maybe I'm mistaken.
But these are also, like the median age here is 16. These are like really young people, and they even had like little people, infants in there. They've even given tecovirimat to the babies. So it's just a very different population.
Yeah. And no one is counting 10,000 lesions, by the way.
I know, 10,824. But you know what I wondered, Mark? I wonder with helminthic and parasitic infections, if there's like if people's immune systems are primed more to that Th2 response, and so the cellular isn't good, and so that's why you're seeing this, or if it's the malnutrition, because I mean, the number of lesions just sounds dreadful.
Staggering, right? Yeah.
So
I think during that session, it was also raised the remoteness of the trial sites was kind of a very limiting factor in sort of how many people you could enroll, and I guess also ultimately who presented to the clinic. So we may also be seeing some
there'll be some bias there for sure.
There that we might be able to smooth over or sort of dilute out in larger populations.
Right.
Good point.
Yep.
All right. Thanks, Seble.
Thanks. Sure.
All right, Sarah, third time's a charm.
Yeah, I send my presentation, so if you can share my screen.
Yes, no problem. I can share them, and then if you could just let me know when you would like me to flip.
Okay.
No problem. Okay. Can everybody see this?
Yes.
Okay.
Yep.
Go ahead.
Okay, so I'll be talking about HIV and menopause and the interaction between them. So this session was based on Dr. King during ID week. So you can go to the next slide. The outline, I'm going to talk a little bit about the epidemiology of HIV in 2024, why menopause is something of importance, the physiological changes that occur during menopause, interaction between HIV and menopause, and whether HIV itself influences menopause, how to treat menopause in the context of HIV, and how hormones, HIV, and ARV all have the potential to interact and influence age-related comorbidities. Next. So the global burden of HIV on women is high. In fact, women globally represent more than half of people living with HIV, and in North America is around 1/4. And importantly, women also have not witnessed the same success of HIV prevention that others have. And so while we have seen an HIV incidence has decreased in men, it still remains stable in women. Next. People living with HIV are aging. And this article was done by Marcus et al., looked at the life expectancy from 2000 to 2016, so over 16 years, and found that people living with HIV have life expectancy increased by 2 decades. And so because of that, we can show the epidemiology curve of people living with HIV and around the world. So the blue line represent high-income countries, and the orange line represent the low and middle-income countries. And you can see across the board the number of people living with HIV aged 50 and over is increasing. Next. So more women with HIV in their midlife years. Also, this data was from the UK, and it was spanning from 2006 to 2016, showing a significant increase in the proportion of individuals aged 45 to 56, which is, you can see it in red in the graph. So over that decade, the age of group grew from a smaller to a much larger proportion of those who are accessing HIV care. And this trend was also noticed globally, not just in the UK. And as a result, with more women living with HIV falling into this age category, we anticipate a growing number of women living with HIV experiencing menopause. Next. So why should we integrate menopause in HIV care? So there's a lot of reasons. The first reason is menopause impact HIV care and vice versa. So there are a number of studies that has shown that women who have increased menopausal symptoms are less likely to take their ARVs and affect their adherence. And also the way HIV impact menopause is by drug-drug interactions. So ARV can interact with menopause treatment, including hormonal therapy. Next. The second reason is that menopause impact quality of life, and we should be aiming for 90% at least of people living with HIV to have a good health-related quality of life. So extensive researches has demonstrated that menopause affect various aspects of life, including work, leisure, sleep, mood, sexual activities. And these challenges are also evidence in studies focusing on women living with HIV. So this shows the importance of addressing menopause to enhance the overall well-being. The third reason is significant impact on systemic health. So menopause characterized by hormonal decline and accelerate age-related comorbidities. And this is especially important because they are the same comorbidities are frequently associated with HIV and antiretroviral therapy, as central abdomen fat deposition, insulin resistant, atherosclerosis, and also worsening bone health. And all these factors, usually three factors, intersect together and can have an adversely affect health outcome. So we should consider the three of them together. Next. So, what is menopause? Menopause is a natural life occurrence experienced by all women who reach the menopausal age, and is characterized by the absence of menstrual cycle for 12 months. Women spend up to third to a half of their life in menopause, and this process usually over years.
Sarah, sorry, I think we're one slide behind. Aniko, do you want to just advance one more slide? Yeah.
Is
Okay.
this the slide that you were on? Sorry.
Yeah, I'm gonna go to the menopausal stage, so I'm done with this slide. So
Okay.
the next one. Sorry. So for the menopausal stage, that there is multiple stages, and basically, the early stage of menopause are marked by changes in the hormone and the menstrual cycle. And it starts for the perimenopausal stage, and then when the menstrual cycle stops for 12 months, we enter the menopause stage itself. And usually, there are major hormonal changes. Sex hormone level tend to be high during reproductive life, productive life, than during menopause fluctuate until it settles at a low level. And why this is important? It's important because these hormonal changes can cause symptoms. So high estrogen levels can cause breast tenderness, heavy menstrual cycle, and worsening migraine. And then low level can cause the vasomotor symptoms as hot flushes, night sweats, and genital symptoms and systemic effect. Next. So, does HIV affect menopause? That's always a question. So, over the past 2 decades, some studies have found minimal evidence of significant difference in the age of menopause between women living with HIV and without HIV. However, some recent studies suggest that women living with HIV may experience menopause slightly earlier, and the most recent study reporting that the average age of 49 for women living with HIV compared to 50 for women without HIV. Also importantly, there is a higher prevalence of early menopause and primary ovarian insufficiency among women living with HIV compared to the general population. And these conditions are also linked to worse health outcome, including increased risk of cardiovascular disease, dementia, fracture, and all-cause mortality. Next. Another question is also raised: does HIV affect menopause? Is through does make any different on the menopausal symptoms? So the literature confirmed that many women living with HIV experience menopausal symptoms. And interestingly, the most common symptoms are joint pain and muscle pain, which is the same as in HIV negative women, rather than the vasomotor symptoms. And when comparing symptom severity between women living with HIV and without HIV, there is not strong evidence to suggest that HIV itself leads to more severe symptoms. However, other factors significantly influence the menopause experience, such as biological, structural, psychological, substance use, elevated BMI, and these factors can exacerbate menopausal symptoms. Next. So, how to manage menopause? Usually, there is multiple strategies. It can range from lifestyle modification to topical therapies to medical treatment. And usually, for vasomotor symptoms, first line now guided therapy is hormonal therapy. Next. So what are the indication for hormonal therapy? As I said, is usually used for secondary use for people who have vasomotor symptoms or early menopause. And for these cases, combination therapy is typically recommended. However, it's essential to check for contraindications, discuss risk and benefit with the patients, and pay close attention to drug-drug interaction. Next. So this slide provides a list of ARVs and their potential interaction with hormonal therapy. And as you can see, there is the NNRTIs, and the ARVs with boosters may interact with hormonal therapy. However, these interactions do not contraindicate the use of hormonal therapy. They only highlight the need for awareness of interaction and potential side effect and adjustment for hormonal therapy according to it. Next. Here was some resources that were provided on how to manage basically menopause with hormonal therapy for general population and for people living with HIV. Next. So here I'm going to talk a little bit about the interaction of HIV, ARVs, and hormones on comorbidity for midlife women. Next. One of the important findings from the REPRIEVE trial is that women have a lower baseline cardiovascular plaque than men living with HIV, but they also had a different immune activation profile, and so they had a higher level of immune inflammatory markers than men living with HIV. So clearly they have different cardiovascular profile. However, the main finding of the trial that statins were just as well in women and men, and there was no sex effect that was seen. This is important because women traditionally are considered to be a lower risk of cardiovascular disease. Next. Also, the trial showed that the cardiovascular risk calculator often underestimates women's risk, particularly in the higher risk group, where women had a significant higher event rate compared to men, and the risk of the women were underestimated by 42%. Next. The last thing I'm going to talk about the weight gain and menopause. So it's known that weight gain on average of 12 pounds during the menopause period and usually happens over 8 years. And it's usually to multiple factors, as mentioned above, like hormonal factor, age-related factor, and lifestyle factors. Next. So peri and postmenopausal women had highest INSTI-related increase in waist circumference and BMI. So this study examined weight gain related to INSTI treatment across different groups. One group consisted of individuals who switched to INSTI, another group who did not switch, and a comparison was made with women without HIV. So looking at the left, we can observe the data for premenopausal women. So in orange, the group that switched to INSTI, in blue, the group who did not switch, and then the gray, there are women who without HIV. And as you can see, the orange and the blue lines show very similar trend, indicated the comparable outcome between those who switched and who did not switch. However, the other side, you can see a significantly changes in women who are basically switched to INSTI and between the women who did not switch and HIV. And you can see that it's very higher increase in waist circumference compared to other in the group of women who switched to INSTI. So this is raises the important concern, especially switching INSTI in women undergoing the perimenopausal transition and who are already at risk for metabolic diseases. So to wrap it up, so hopefully I highlighted the significance of menopause in the context of HIV, with increasing number of women living with HIV and transitioning into menopause. And we're seeing like a profound effect on their quality of life and their HIV management and in age-related comorbidities. Thank you.
Thank you, Sarah. Very interesting. I had a question. So you said it's not clear if HIV in and of itself affects menopausal symptoms. You said that the data is not clear on that, but there's a suggestion that it might.
So it does not So the type of symptoms is not changed. Both was like seen as like the joint pain and the muscle pain more common, and then itself does not affect the severity of the symptoms. Other condition and other factors such as like psychological or biological or like socioeconomic or substance use may have more impact on the severity of symptoms.
So when you said in your first slide that the studies have shown that women living with HIV who have menopausal symptoms are more than twice as likely to have poor adherence to the antiretrovirals, that's just because they're feeling poorly otherwise, that they just can't take the antiretrovirals as regularly.
Exactly. Yes.
It's not a specific symptom that's necessarily related, that it's just a general sense of poor well-being.
Exactly, the well-being of them.
Yeah.
So just to answer to your question, Dr. Greenberg, a lot of these studies were done in the WISE, now Max WISE, including the last study that you just presented, Dr. Abelman's study, that showed, we've seen the weight gain with INSTIs, and there have been a number of publications in women from the Max WISE. But I think this one was really the one that I think for me really stood out, was where do we see the change and does it matter? Because, when you see these small incremental 0.6 millimeter, whatever waist circumference changes, it's not that dramatic. But then my clinical experience is that there'll be a group where you don't see a lot of change, and then you have these outliers where there's a huge amount of change. And who are they? And I think this really helps us start to understand that it could be this perimenopausal shift, where maybe that would not be the best time to make a switch to an integrase-based therapy. For those who are already, there's a lot of questions still there. If you're already on an INSTI, would you still have accelerated weight gain, etc.? But it's not a clinical trial, so these are observed data with a lot of there are going to be confounders there.
I think Tamara has a question.
Yeah, I just have a kind of a random question per usual. But thinking about kind of in the clinical space. So I think, again, all the presentations were really good. But this last one I was thinking about, we had a study, a pilot, DC CFAR pilot that was with Black women living with HIV, and to which in the qualitative arm, so again, small sample, but a number were kind of talking about these concerns around menopause and feeling like it's sort of this black box. And when they're trying to kind of interact with their provider, it's so kind of focused on their HIV that the menopause aspect is kind of getting dropped. And I'm just curious if you all could just share a little bit about how, from like a clinical provider patient relationship, how menopause is being communicated to women living with HIV, and how maybe these findings can support I hate to say better communications, but just I heard time and time again this sort of, I feel like I'm just in this black box and I know something is happening to my body. I can feel that it's not just just HIV, but it's something else. And I think it's this menopause thing that I don't really know, what's happening, and I can't really find the resources or the information I need. And